I would like to welcome everyone to our February webinar. This is a joint webinar organized together by ILTS Vanguard Committee and Turkish Association for the Study of the Liver. This is very exciting that we have this collaboration. Before we begin our presentations, there are a few announcements as always. All participants will be muted and the videos will be turned off except for the speakers during the presentations. You can either submit a question to the speakers over the chat, and moderators will lead the discussion at the end of each presentation. However, you can also unmute your microphone at the end of the presentation and ask the question directly to the speakers or make a comment. This webinar will be available on the ILTS website as a recorded version in about a week. If you have interesting cases, please submit them to ILTS. At the bottom, there is actually an address, or you can email them directly to me, the Vanguard chair. So the one more announcement, and sorry, I apologize. Ryan Chadha, are you on the line?
I'm here, yes.
Yes, please talk about your new initiative by Vanguard before we start the presentations.
Perfect. Thank you so much, Varya, and I'm looking forward to today's session. Super exciting. Just want to give a quick teaser to our new initiative that's coming out, the ILTS Vanguard Twitter Journal Club, which you can see the date is there. The Twitter Journal Club is a slightly different format to how we do things. It's going to be purely via social media. So as you can see, the article that we will be discussing is a recent very interesting article that was published in Journal of Hepatology. So please, this is just purely a teaser. You will get more details about the Journal Club via email probably within the next week, but we just wanted to mention it here for the first time as it is a Vanguard initiative. Thanks, Varya, and good luck to all the speakers.
Thank you, Ryan. So now I would like to present our two moderators. First moderator is Carmen Vanaisa from Valencia, Spain, and the second one is Zeki Karasu from Izmir, Turkey. Carmen, please go ahead.
Okay, good morning, good afternoon, and good night to everyone, and thank you for joining us in this Vanguard webinar, Complex Liver Cases webinar. The first case will be presented by Dr. Lisa Lartigo from the Paul Brousse Hospital in Paris about management of hepatic artery complications after liver transplantation. And at the end, also Dr. Nicolas Golso will be joining for the questions and answer sections. So please, Dr. Lartigo, go ahead with your case. Thank you.
So hello, everyone. Thank you all for attending this presentation. Today, I'm going to talk about the management of hepatic artery complication after a liver transplantation, starting from a case we had in our hospital. I have no conflict of interest. So this is about a young 19-year-old male with no medical history, weighing 76 kilograms, who had a drug intoxication with acetaminophen. His clinical symptoms at his admission were abdominal pain, and had no flapping. His biological results were an inflammatory syndrome with leukocytes at 23 giga per liter. He had the hepatic cytolysis with AST at 2000 and ALT at 3000, and his prothrombin ratio was at 10%. He arrived at our hospital at day 3 after his poisoning. We gave him N-acetylcysteine, and the dosage of his acetaminophen in his blood was 28.5 milligrams per liter. He has clinical symptoms who deteriorate with a confusion, so he had an encephalopathy grade 3, and we needed to orotracheal intubate him. His prothrombin ratio decreased at 5%, and his factor V was at 7%. His cytolysis increased, and his lactate were at 13.3 millimole per liter. He had no kidney failure and no acidosis. So according to the King's College criteria and to the Clichy's criteria, he had acute liver failure. And we know that in this case, the short-term survival is quite bad if we don't transplantate this kind of patient, with only 35% of survival without the transplantation and 84% with the transplantation. So we decided to start the liver dialysis mass, and we listed him on the national transplant waiting list in an emergency procedure. We have a graft for him after 24 hours after the admission, so it was day 4 after his poisoning. It was a whole liver from a 24-year-old man. This is drawn. The patient had only 30-minute low flow. The graft weight was 1,300 grams, and the liver function was normal. The graft had an anatomical variation. It was a type 4 arterial variation with a replaced right hepatic artery from the superior mesenteric artery, a replaced left hepatic artery from the left gastric artery, and a proper hepatic artery from the common hepatic artery. The recipient had the model anatomy. So this is the picture of the graft, with the superior mesenteric artery here giving the right hepatic artery, the celiac trunk with the splenic artery, the left gastric artery, and the common hepatic artery. So we needed complex reconstruction for this anatomy. We had to do 2 anastomoses. We anastomosed the donor superior mesenteric artery with the donor splenic artery. So here is the first anastomosis between the splenic artery of the graft and the superior mesenteric artery. And the donor celiac trunk was anastomosed with the cuff created with the recipient common hepatic artery bifurcation and the gastroduodenal artery. Here we have the graft's celiac trunk with the common hepatic artery and the gastroduodenal artery of the recipient, which were anastomosed. For the other anastomosis, we did what we usually do for transplantation in our hospital. For the vena cava, we used the piggyback technique with the native vena cava conservation. So you can see here the 3 hepatic vein cuff where we do the anastomosis, just as in this scheme. As the portal vein was an end-to-end anastomosis, and for the biliary tract reconstruction, it was also an end-to-end choledochostomy. The liver transplantation went well, with a portal ischemia of 9 hours, an arterial ischemia of 10 hours and 30 minutes. It was a bit long, but it was because the complex reconstruction we had to do on the back table. The operative time was 8 hours. We didn't need to transfuse the patient with red cells nor with platelets. And we gave him 3 fresh frozen plasma. He stayed hemodynamically stable for all the procedure without vasopressor. Both the donor and the recipient were negative for the CMV. The postoperative outcomes went first well, with a decreasing of the hepatic cytolysis from postoperative day 0 to day 2. Then at day 3, we observed an increasing of the cytolysis. The prothrombin ratio and the factor V increased normally from postoperative day 1 to day 3, but the Doppler resistive index decreased from postoperative day 1. It started 0.7 to 0.4 at postoperative day 3. So given the fact that the cytolysis increased and the Doppler resistive index decreased, we decided to do a CT scan to see if there was any problem with the graft. So here is the CT scan. You can see first there is a collection just below the liver. And for the arterial anastomosis, you can see here there is either a stenosis or a kinking. We didn't know exactly, but the anatomy was normal. So here are the key images. We had a voluminal perihilar collection, and we feared it was a biloma. And we had the suspicion of arterial kinking because of the long graft artery. So we decided to go to surgery because we were at day 3. It was very soon after the transplantation. And during the surgery, we had no biloma, but the partitionated ascites, and the right hepatic artery was kinked. So we decided to do a nomental interposition to treat the arterial kinking. And the Doppler resistive index during the procedure were correct at 0.5. The postoperative outcomes were satisfying with a decreasing of the hepatic cytolysis. The Doppler resistive index at day 13 after the transplantation and then day 10 after the new laparotomy were correct at 0.58 for the right artery and 0.67 for the left artery. We did a new CT scan 3 days after the new laparotomy, so 6 days after the transplantation, to check that there was no more arterial kinking, as you can see here. Finally, the patient was discharged 20 days after the transplantation. The post-operative follow-up went well at 1 month with right and left resistive index at the Doppler at 0.66 and 0.56, which is satisfying. The liver function was normal, but when we did a CT scan at 49 days after the transplantation, it's a systematic scan, we saw that there was a stenosis on the hepatic artery anastomosis. The liver function was still normal. Here is a scan at 49 days after the transplantation. And you will see just here, there is a stenosis. And the flow after the stenosis is not as good as it used to be. First, we decided to control it 2 weeks after. We did a new CT scan. We were at 2 months after the transplantation, and the stenosis was stable to this new CT scan. The resistive index were not satisfying, with the right artery resistive index at only 42, 0.42. So we decided to treat this stenosis by endovascular therapy, angioplasty, and stenting. So here are the images. This is before the stenting. We can see the stenosis here. And then after the stenting, we can see the stent here, and the flow after is better. Here's a stent and the flow after, which is good. The follow-up after the endovascular treatment was satisfying, with a Doppler resistive index 3 weeks after the angioplasty, which were good at 0.48 for the right artery and 0.59 for the left artery, and the liver function was normal. We did the last CT scan 2 months after the endovascular treatment, and that was only a few days ago. And everything was all right. The stent was at its place, and the flow was so here is the stent and the flow after, good. So now we will compare the management of this case with what is described in the literature. First, let's discuss about the early arterial thrombosis and the kinking and their management. So Herrero et al. Described several risk factors for hepatic artery thrombosis. Concerning the length of the graft artery, the rate of the early hepatic artery thrombosis was greater with a long graft artery than with a short graft artery. And in our case, we had a long graft artery because of the reconstruction we needed to do. Concerning the recipient arterial sites and the graft arterial sites of the anastomosis, we didn't have the risk factor enlightened by Herrero et al. Although the donor arterial variation and complex reconstruction were significantly associated with a long graft artery compared to the short graft artery, these two variables were not significantly associated with the early arterial thrombosis in their study. Another thing which is surprising is that there was no association found between patients with or without arterial kinking prevention. So that was not a mistake not to do the omental flap during the transplantation. And finally, there was no benefits found in the group of patients who received prophylactic acetylsalicylic acid therapy instead of not giving them the therapy to prevent the artery thrombosis. In our case, the patient had acetylsalicylic acid therapy just after the transplantation, but there is no proof that it improved the results for thrombosis. We chose to do one kind of anastomosis, anastomosing the superior mesenteric artery with the splenic artery, but there is another technique possible, which is a Gordon's technique, and which consists on folding the aortic patch to anastomose the celiac trunk with the superior mesenteric artery. It's also a long graft artery with no evidence of benefits compared to the patch on the splenic artery we chose to do. So when it's possible, Lorenzin et al. Described the best arterial anastomosis as straight as possible to avoid any kinking, redundancy, or malposition of the artery when the liver is released. In our case, that was not possible because of the arterial variation. Panaro et al. Described the possibility of doing a nomental flap, which is a strategy we decided to use when we do the second laparotomy. This is a technique inspired from the pancreaticoduodenectomy, and in this study, they explain just how to do the omentoplasty. They did another study, Panaro et al., where they showed that the anti-kinking methods, such as the omentoplasty or the interposition of Surgicel, permit to get a better flow in the arterial. Here in the picture, you can see the flow on the artery before releasing the liver in its final position. Then after releasing the liver in its final position, but without having done anti-kinking prevention methods. And the flow is again measured, but with the omental interposition, and the flow is better with the anti-kinking methods. In this study, Panaro et al. Didn't find any significant association between the thrombosis and the anti-kinking method, but they just show the flow is better when we do the anti-kinking method. Maybe that was not enough powerful study, and maybe we have to do a new kind of study like that with more patients to show a significant association for the thrombosis. Another technique described by Cheng et al. To prevent arterial kinking is the use of the fibrin glue. They described it in the living donor liver transplantation. In their experience, the kinking site is usually located in the anastomosis area. So they used to stretch the artery and to spread fibrin glue on the anastomosis to prevent any bleeding and to have a sealing and to prevent the kinking too. So maybe it's a lead for the liver transplantation when we have a long graft artery. So now we will discuss the hepatic artery stenosis. After autotopic liver transplantation, hepatic artery stenosis is a classical complication, the incidence of which is reported to be approximately 3 to 11% by Abbasoglu et al. Untreated stenosis leads to hepatic artery thrombosis in about 65% of cases within 6 months. And the risk it is a risk factor for ischemic cholangitis, then graft loss in 53% or patient death in 33%. Some risk factors have been enlisted by Baker et al. For this stenosis and this thrombosis, such as the duration cold ischemia, which was a risk factor in our case because of the complex reconstruction we had to do, and the arterial variant, which was also a risk factor we had for this patient. To early detect and prevent these stenosis, in the study of Memeo et al., which is a study of our team, we recommended to realize a systematic CT scan at the end of the first week after the liver transplantation to early detect and treat the arterial complication. In this study, we showed that the surveillance significantly decreased the rates of retransplantation for late hepatic artery thrombosis, leading to graft loss. The result from the earlier discovery arterial complication, even if no significant association was showed, there was a real trend to detect earlier the arterial stenosis. Thanks to the systematic CT scan at the end of the first week, it was possible to identify asymptomatic patients with high risk of arterial thrombosis, and we treated the severe stenosis more than 50% with endovascular treatment. So when we detect stenosis, Mockham et al. Suggested the use of a systemic vasodilator to prevent arterial complication. They used amlodipine and nicorandil as soon as they saw that Doppler resistive index were below 0.5. They used these drugs for 48 hours in all their patients, and then after 48 hours, they measured once again the Doppler resistive index. In about 1/3 of their patients, there was a normalization of the indexes. For 1/3, there was only an improvement, and for 1/3, they had no response. The use of the systemic vasodilator was safe with few minor adverse effects only for prolonged administration. And in their opinion, they could prevent more invasive therapy. In my view, more studies need to be done for the use of these vasodilators. We should do a randomized double-blind study with systemic vasodilator versus placebo to evaluate the real benefits of this therapy. But as there is no adverse effect, we can use these vasodilators as a waiting treatment for stenosis. And we could have used it for our case because we decided to wait 2 weeks before to control with a new CT scan the stenosis for our patients. When this is a failure, when the systemic vasodilator doesn't work, we have to treat the patient in another way, whether by surgical revision or by endovascular technique. And Abbasoglu et al. Showed that there is less morbidity and mortality with similar rates of success for endovascular technique. So when we decide to do an endovascular technique, we have 2 possibilities, whether the transluminal angioplasty alone or the stenting. And Magland et al. Compared both of these methods. The primary effectiveness of both methods were similar, and there was no difference between both methods in terms of complication. But for the long-term result, there was a trend in favor of the stenting, which shows that there is best results. The best results are with the stenting. So as a consequence, for complex hepatic artery stenosis, it seems to be preferable to use the stent as a first-line treatment instead of the angioplasty alone. So as a conclusion, we had 2 arterial complications early detected and treated before more serious damage on the graft. I think the take-home message of this one, it's interesting to monitor very intensively our patient with transplantation with Doppler ultrasound and CT scan to treat very early the stenosis and the early thrombosis. In the case of long graft artery, we have to ask ourselves if it's not interesting to do anti-kinking methods systematically, even if there is no proof of their interest for now. If it's not very difficult to do an omental flap, and it could prevent the kinking. And for the treatment of stenosis, I think we could try to use as a first-line treatment the systemic vasodilatators, and a second-line treatment, always do a stenting and angioplasty, but a stenting too. Thank you for your attention. If you have any question.
Thank you very much, Dr. Lartigue, for your excellent presentation and very interesting. We'll start with the question sections. There was a question from Dr. Berenger asking what is the rate of arterial complications in your center, and if you have seen an increase in the recent years as the quality of the grafts have worsened.
I'm talking on control of Nicolas Gols, but I think the rate of arterial complication are the same in our center than in other centers, and I don't think we had an increasing of these complications with the different graft and the quality of graft we use for now.
Yes, it increased if we compare with 10 or 20 years ago with marginal donors. Unfortunately, we observe a more frequent complication rate, and particularly arterial complications. Yes.
Okay, thank you. And have you seen any difference when you are transplanting in an urgent manner, as this was this patient with a fulminant hepatitis, than from another type of transplantation?
No, I don't think so. And in this case, the donor was a young donor. So I think the problem was the artery, the anatomy of the liver with 3 arteries. But we were quite surprised by the occurrence of this complication.
Okay, thank you. There was another question. Yeah, of course. Go ahead, Dr. Emery.
Hi. That the one thing that just it's really important if your arterial anastomosis is long. What I do after I close the abdomen without putting the skin stitches, I always get an ultrasonogram, because when you close the abdomen, then everything is going to change and tissues and organs may shift. Then kinking may occur. If that's the case, and opening the sutures and then positioning, avoiding all these problems, and would be really valuable. Thank you.
Thank you, Dr. Emery. We would like also to discuss if you are recommending long-term double antiplatelets, antiaggregants after stenting, meaning using aspirin with clopidogrel, for example.
No,
and for how long?
You are asking me?
Well, I was asking the
Everyone.
presenters.
Okay.
Yeah.
Okay. All right. Thank you. Thank you.
No,
Maria.
usually we only recommend double antiaggregant during a short period, and after, as for all the recipients, we recommend a long-term aspirin.
Okay, thank you. We'll go ahead with other questions. There was also some concern regarding if fibrin glue can cause arterial obstruction. Could you comment on this?
Very honestly, we don't use a fibrin glue. It is Lisa talked about this because it is we see sometimes this technique in literature, but we don't use it in routine. So I have no experience about these tips.
Okay, thank you very much. We have one last question, since we have to go on with the second presentation, and it's just a comment. If anyone knows or is using prostacyclin in difficult arterial anastomosis, I don't think we have any evidence on this. Could you comment?
No, agree with you. No evidence, and we don't use it. I think in case of difficult arterial anastomosis, the better advice would be to use some surgical loops and very, very thin suture.
Okay, thank you very much. Well, I would like to thank you one more time for your presentation, and we will go on with the second case of today. Thank you.
Okay. Hi, everybody. I would like to thank you all for joining us today for ILTS Vanguard Complex Liver Cases webinar in collaboration with Turkish Association of Study of Liver Disease. We have just watched a case discussion related to management of hepatic artery complications after liver transplantation. In the second part of the webinar, the topic will be the evaluation of liver mass following liver transplantation. Another case will be presented by Dr. Hale Gökçen. Hale Gökçen is an associated professor of gastroenterology at Ankara University School of Medicine, Ankara, Turkey. And there will be two discussants. Both of them are experienced in the field of liver transplantation. One of the discussants is Gökhan Kavaçam, professor of gastroenterology, Ankara Güven Hospital, Ankara, Turkey. And the second discussant is Ramazan İdilman, professor of gastroenterology, Ankara University School of Medicine. Ramazan İdilman is also ex-president of Turkish Association of Study of Liver Disease. And I would like to invite Dr. Hale Gökçen to present her case. Lale, microphone is yours.
Thank you, Dr. Karasu. Dear colleagues, chairs and panelists, I am Dr. Hale Gökçen from Ankara University. I would like to present a case in this complex liver cases session. I have no conflict of interest. Our case here is a 58-year-old male who was seen in hepatology outpatient clinic for post-transplantation routine control. He had cadaveric liver transplantation for cryptogenic cirrhosis at 2018, and he developed de novo hepatitis B infection 2 years after his transplantation. There were no comorbid diseases like diabetes, hypertension, no metabolic syndrome. His past history was uneventful except a tympanoplasty surgery, and he lost his mother with esophageal carcinoma in his family history. He denied smoking and using alcohol, and his medications were as follows. The physical examination was normal except incisional scar. When we looked at his hepatitis markers history, he was transplanted at 2018. Then at June 2020, is HBC antigen and HBe antigen positivity and elevated HBV DNA were detected, and he was evaluated as having de novo HBV infection. At this time, the only risk factor was his dental procedure, which was performed 5 months before the incidence. The donor HPC antigen was negative, but we didn't know the IgG anti-HPC status. To date, the HPC and HBE antigen positivity persist, and HBV DNA became negative with antiviral therapy. Lab results during follow-up period on 28 months after liver transplantations were as follows. His complete blood count, blood and urine biochemistry values were within normal limits. He had HPC antigen positivity with negative HBV DNA with antiviral therapy. So we ordered a hepatobiliary ultrasound which revealed a 15 millimeter hypoechoic lesion at segment 7. And until now, follow-up ultrasound reports from outside radiology clinics were all normal. What is the next step and what is the diagnosis at this stage?
Good evening, dear colleagues, ladies and gentlemen. This is great case, Dr. Gökcan, you presented. I mean, as you know, that liver transplant recipient can develop benign and malignant hepatic masses after liver transplantation, just like immune-competent individuals. It's important to distinguish this benign lesion from malignant lesion in order to prevent unnecessary treatment. I mean, the benign lesion or the liver mass are discovered incidentally by ultrasonography or CT scan, as like your patient. At this point, I mean, this lesion came from the donor, because as far as I know, this donor is cadaveric donor, deceased donor, or this lesion maybe they need to develop after following the liver transplantation. I mean, at this point, I recommend to use abdominal imaging technique, including contrast NSAIDs, computerized tomography, or magnetic resonance imaging. Evaluate the need to develop the liver mass. Gökhan, do you have any comment at this point?
So I completely agree with you. This is a lesion either newly developed or somehow we have missed it before the transplantation, because it's coming from the donor side. We know that in the cadaveric donor transplantations, we sometimes can see low quality CT or imaging studies that can miss small lesions, and this can be a lesion coming from the donor side, or we have a case here with the de novo hepatitis B. Although it's a rare case to have a de novo HCC development in 1.5 years' time with hepatitis B infection, de novo hepatitis B infection here. Even HCC can be the case, or some metastatic lesion, oligometastasis to the liver, because it's hypoechoic, it says. So I would completely agree and go for a contrast enhanced CT or MRI in this instance.
Gökhan, may I have your opinion about the HPV status of the patient that somehow may be related to the evaluation of the mass? Is HPV does HPV positivity come from the donor, or do you think that's the de novo or acquired HPV?
This is a very nice question. We see it's an e antigen positive case with the early hepatitis B infection with a 6 months ago a suspicious dental procedure. But we should keep in mind that in the evaluation of the donor, we somehow have missed the core antigen, antibody, immunoglobulin G status. So we can not be sure whether this hepatitis B is a de novo hepatitis B coming from the donor side or from the external contagion.
There are also several questions about.
I have a question and some comments, if I'm allowed. May I?
Yeah.
Sure,
So that
Please.
number one, that regarding Zeki's question, that any donor-derived in malignancy, 2 years is kind of late. Usually, I have a couple of cases and such that if this donor-derived, and usually, and you can see within 6 months or so, 3 to 6 months, then you can see and it doesn't present with one single 15 millimeter lesion. The liver is full of lesions, basically, or lungs, and wherever it is, it's a very aggressive picture. In that sense, and I don't think it is, donor related something. But if that's the case, there's only one way that we can find, if donor is female, that this recipient is male, I believe, right? So that then you can do a fish testing that you can, if that's a tumor, you can get the tumor specimen and do the fish testing to find out whether it's coming from donor or not. And the other thing is, this is early days, and we thought that early 1990s, hepatitis B core antibody livers we can use safely. That we learn, and usually average recurrence time, if you don't do protection, if you can transplant hepatitis B core positive livers, but if you don't use any protection, if you don't use any HB or old days or any antivirals, then recurrence is inevitable. Then the average time to recurrence is somewhere around 18 months. That's our previous studies showed. So this case is similar to that, but I cannot attribute the lesion to early cancer related to hepatitis B. It's really early, and I agree with Gökhan actually with that.
Okay. Thank you very much, Professor Emre. Dr. Karasu, there are several questions about the AFP level of the patient. As far as I know, that AFP was normal, and the core antibody status, as Hale mentioned, that Dr. Gökhan mentioned, that was unknown during the transplantation. Let me say a couple of, if you don't mind, let me say a couple of things about the best diagnosis of the new diagnosis, the mass after transplantation. It could be the benign lesion, or it could be the malignant lesion. As you know, that the most frequent solid benign lesion of the liver is the hemangioma, followed by focal nodular hyperplasia, hepatocellular adenoma, and also angiomyolipoma. It could be the malign lesions such as the HCC or big stip HCC or neuroendocrine tumor. The chairman, if you don't mind, we will forward.
Okay.
Yes, please, Hale, go on.
As Dr. Edelman mentioned, in patients with liver mass, there may be benign or malignant lesion in differential diagnosis, as in this shown in this table. We checked the pre-transplant donor abdominal CT for any pathologies, and but the imaging was performed without contrast, and there was no lesion in the liver. And then we ordered dynamic abdominal MRI as the next imaging modality. On coronal and axial T2 weighted images, subcapsular 15 millimeter lesion was seen at segment 7, which appeared hypointense in T1 images and hyperintense in T2 weighted images. However, he noted that there was no diffusion restriction. In face and in opposed face imaging, there were no appearance of fat in the lesion. In dynamic examination sequences with hepatospecific contrast agents, the lesion showed intense enhancement in arterial phase and showed iso-intensity in portal and late venous phases. The lesion showed no washout sign, but the lesion was hypointense in hepatobiliary phase. The MR elastography showed 3.2 kilopascal, indicating the F1 to 2 fibrosis. Regarding the F1 to 2 fibrosis at MRI and underlying the HBV infection, the radiologists found this imaging characteristic with hypervascularity and the T2 hyperintensity suspicious of for HCC. And using the LIRADS classification, these findings were evaluated as LIRADS 4 lesion. And what is the next step at this stage in this patient?
May I comment here?
Yes.
Actually, this lesion has a similar characteristic with HCC, but an important issue here is there is no washout. So I would be in doubt and I would order another CT scan. Dynamic CT may be better, maybe to differentiate between a newly developed HCC and hemangioma. Here, AFP was normal as far as I can see, and as Professor Emre mentioned, if this would have been an HCC, it would be surprising to find one in this time of the post-transplant period. But still, the radiological diagnosis is very important. The gadolinium enhanced MRI is very sensitive to differentiate for the HCC. So I think a biopsy should be another step forward.
Okay, thank you, Gökhan. Also, I would like to say that, I mean, there is an enhancement in arterial phase, and as Gökhan mentioned, that there is no washout, newly established, newly detected lesion in the liver. I would like to recommend biopsy, if possible. But this is a small lesion, maybe in deep of the liver. I don't know.
Well, it's on the surface for sure, so it's not deep, but the approach might be not easy because segment 7 lesion, right, Ali, you said?
Yes.
But the problem is 1.5 centimeter lesion. It's not more than 1 centimeter. A good intervention radiologist will be able to get the specimen out. So the question is, you know, after the biopsy, would you like to treat it, or would you like to do something since the intervention radiology there or not? What you guys think about it?
Yeah, it's a deep lesion, as we see in the MRI. Maybe Halek could go back in the slides to show the place. yeah, although it's by an experienced radiologist, maybe it can be possible, but it's very difficult to approach this place. And sometimes we need to go for even surgical exploration in so-called newly developed lesions like this in the post-transplant periods. Of course, as I mentioned before, this non-contrast enhanced CT before the transplantation makes us in doubt, because this can still be an hemangioma because there's no washout. So I'm excited to watch what's coming.
Guys, may I ask you that LIRADS, the liver imaging reporting and data system, is it applicable for that patient?
I mean, thank you very much. This is a very good question, dear Chairman. I mean, as you know, that LIRADS classification is applicable in the cirrhotic patients. And also, LIRADS classification is applicable of the HPV-induced liver diseases. Maybe we can, we have the F1, F2 fibrosis in this patient. It might be used in LIRADS classification in this patient.
Yeah, this is why I asked Gökhan a few minutes ago about the duration of HPV infection. Is it donor-derived or just a couple of months ago acquired HPV infection? Because it's donor-derived and there is a chronic fibrotic change in liver, then LIRADS can be applied.
Okay. But Hale do, I guess.
Okay. We ordered the FDG PET as the next non-invasive imaging modality for a malign lesion workup, and no FDG accumulation was noted in the lesion. Then, do you recommend aspiration biopsy?
In this moment, that was the answer of one of those questions. One of the audience asked, did the donor have any other extrahepatic malignant condition? Then PET-CT showed no other extrahepatic malignancy.
Yes.
Okay, go on, Ale.
We evaluated the patient for ultrasound-guided liver biopsy again, but we declined the biopsy procedure because the lesion was subcapsular and small and technically difficult to perform a safe biopsy. And besides, negative pathology would not reject the HCC possibility. What should be done in the next step?
I would check the dynamic CT scan right now, because I am not sure with this the lesion without the washout is typical of HCC, and it's, as Dr. Karasu mentioned, it's very atypical to see a HCC case, a de novo HCC case in a patient without prior HCC before the transplantation. He was cirrhosis, cryptogenic cirrhosis, and even de novo hepatitis B or donor-derived hepatitis B is very, it would be surprising that we see an HCC in this patient.
Yeah, Gökhan,
I have my comment.
HCC, but we are not sure this lesion is malignant. Most probably it's a benign lesion.
My take is, I wouldn't rush anything. I wait, and I will do a better study within 2 months, because less than 2 centimeter tumors, and we used to call this that, just we saw those lesions many times, and there is a tumor less than 2 centimeters is a stage 1 tumor. You always have time. So then either 1 month or 2 month good imaging study with good follow-up with tumor markers would be suggested.
There's a similar comment from the chat as in line with your comments, short-term imaging, says Dr. Faisal.
Okay, I mean, as discussing already mentioned that the diagnostic management depends on the clinical background. If this patient, if this recipient transplanted to HCC, I mean, the new mass, the detected mass should be carefully evaluated and perform the biopsy or consult the surgery. But there is no HCC before the transplantation. It could be check the radiologist for the again the diagnostic evaluation, and its meantime the treatment for local ablative treatment, or it could be, I mean, it should be wait another 3 months and apply again the same diagnostic evaluation. What did Hale do about the patient?
Yes. On dynamic MRI, a 15 millimeter lesion was evaluated as LIRAS-4 lesion, and the HCC risk is 74%, and overall malignancy risk is 80% in a LIRAS-4 lesion. According to the ASLT guideline, the LIRAS-4 lesion is evaluated as probably HCC and become consistent with our approach. The findings were evaluated as LIRAS-4 lesion, and as suspicions for HCC was high, we consulted interventional radiology for RF ablation of the lesion, but they rejected the procedure with the same reasons. Then we discussed the patient at the surgical board, as the performance status of the patient was good and the risk of HCC was present. Surgical resection of the lesion was decided, and the lesion was resected at July 2021. Post-operative pathology revealed in this low magnification a well-circumscribed vascular lesion in the hepatic parenchyma, and the lesion was composed of thin-walled vascular channels filled with blood. At higher magnification, these vascular channels were lined by flat endothelial cells with no cytologic atypia, and the wall of the vascular spaces showed fibrous tissue. And the non-tumoral parenchyma showed portal and lobular inflammation, and portal fibrosis is seen by trichrome stain, and the parenchymal architecture was intact, no cirrhosis. And the lesion was obviously a cavernous hemangioma. The LIRAS classification is used in cirrhotic patients and also in HPV-infected non-cirrhotic chronic liver disease. And according to LIRAS classification, the findings were evaluated as a LIRAS-4 lesion. But when we looked retrospectively to the same MRI, the post-contrast subtraction images, the minimal progressive contrast enhancement sustained in the lesion after arterial phase. And there was no diffusion restriction, which is expected in HCC. On the contrary, ADC mapping showed hyperintensity, which mostly indicates benign lesions. In summary, we may encounter hepatic masses after liver transplantation, and those may be malignant as well as benign lesions. There are multiple test or treatment alternatives for these lesions, especially the dynamic imaging modalities are the most sensitive tools in the differential diagnosis, and the decision should be given in the multidisciplinary fashion. Thank you for your attention.
Thank you, Ale. I think, Ramazan, we are over time, and I would like to thank.
Just mention a couple of only small thing. I mean, it was last 4 after the red check the MRI imaging. There is a ADC hyperintensity, and right now, I mean, at that time the last 4 to decrease the last 3 till the carrying on the HCC, I guess. Because after the ADC is last 4 decreased the last 3.
Ramazan, I'm going to say one thing, and it's really important that sometimes mucking around and acting very fast, that you can harm the patient. This was a small tumor, and then there was no increased risk, and there was no risk factor, putting everything together, taking into consideration, and this patient could have waited, and then gain some time and evaluate with, you know, maybe 1 or 2 months later imaging studies, and making more, you know, solid decision that the surgery could have been avoided.
Yes, we definitely.
Can I give a short comment?
Mm-hmm.
Last comment, maybe. If this patient would have been a live donor liver transplant, this would never happen, because the donor would have been has the dynamic CT, volumetric CT scan, and if he or she had the lesion, we would have known it beforehand. So this may be a unlucky situation, but the results are not too bad, as far as I see. Even with the hemangioma in the donor before the transplantation, I think many of the teams here would go for it and do the transplantation. There are several reports in the live donor and diseased donor transplantation in the donor with hemangioma. So, thank you.
Okay, thank you again. I guess there will be some announcements from ILTS, and I'd like to pass microphone to ILTS board.
Thank you very much.
Thank you.
Well, thank you very much for the wonderful discussion. I am going to share again my screen. I hope this will work. Again, thank you to the ILTS Vanguard Committee, as well as Turkish Association for Study of the Liver. This was fantastic. We had 100 participants, and actually some people could not join due to the limit of our registrants. So the ILTS, actually this webinar will be available online and recorded in the future. Again, for next month, we'll have 2 excellent centers from 2 different sides of the world presenting. First, if a case will be presented by the team from Northwestern University in the United States, use of arterial conduits from the common iliac artery to the hepatic artery in liver transplant recipients. The second will be presented actually again as a collaboration with acute liver failure special interest group of ILTS by the group from Beijing Friendship Hospital for China, and it's going to be present and future of liver pathology in acute liver failure, discussion around 2 illustrative cases. Please join us, and again, contact Vanguard if you would like to present your cases and actually do joint webinars, because I think this is a great way to collaborate with many people across the globe. Thank you again, and have a wonderful weekend.